All right. YouTube is rocking and rolling. I just have to fix the B button there. Okay, here we go. Greetings, everyone, and welcome. My name is Eric Glazer, and you have joined our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together each episode to inform you, but also unearth bright spots, successes at health plans, hospitals, and other healthcare-related organizations around the country. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared on our show can be applied at your organization. We believe this strategy of finding a bright spot and cloning it is the most effective way to improving healthcare in our lifetime. For those of you who are new to Bright Spots in Healthcare, I ask you the favor of looking us up on any podcast app that you use. Type in Eric Glazer or Bright Spots and subscribe, and you will get every single episode downloaded to your tablet. We've had an unbelievable roster of guests this year, and we typically take our live recordings that we're doing here via Zoom, and we drop them into the podcast feed within 24 hours. And we also do somewhere between 6 and 8 one-on-one interviews as well, in addition to our live recordings with leaders in the industry that always have a lot of great ideas and industry insights that you can all benefit from. So subscribe to Bright Spots in Healthcare. You could also go to our YouTube channel if you prefer video and you want to look at me. You could certainly subscribe to our YouTube channel, and we have all of our episodes there as well. In about 45 minutes, I'm going to be asking you for some feedback. It's going to come by way of an email, yet another email, and it'll be SurveyMonkey, and it takes 3 to 4 minutes, my data says, to complete it, and it'll be asking you around what we should cover in 2023, as well as how we could improve our performance each episode, providing me and my producers feedback around this particular episode. So I thank you in advance for taking the time to do that. We have an incredibly exciting and interesting topic today. It's on co-designing social care for payers and providers. And we have a very unique and special sponsor to support today's episode. They are the Partnership to Align Social Care. The partnership is a collaborative that includes leaders amongst community-based organizations, health plans and health systems, national associations and advocacy organizations, philanthropic organizations, foundations, academic institutions, federal agencies, and other key participants. And they all collaborate to co-design a strategy to enable successful partnerships between healthcare organizations and networks of CBOs to deliver better social care services. I'm going to tell you a little bit more about them during the episode, but what will be unique about this episode is a lot of the bright spots and a lot of the ideas you're going to hear today are from participating members of the said collaborative and what they're doing around social care. So you'll get a sense of that throughout the theme of today's questions, but I'll also take a brief moment later on in the show to tell you a little bit more about them. If you're intrigued and you haven't heard of them before, you could check them out right now at www.partnership2asc. That's the number 2 asc.org. So partnership, the number 2 asc, one word, .org. You could check out their website there. We have an embarrassment of riches for you today with an exceptional panel, and we're going to provide all kinds of ideas and bright spots for you. We have incorporated some of the folks who registered for the live recording, asked questions upon registration. We've tried to incorporate some of those questions into our plan for today. You can also help me co-moderate, as many of you often do, through the Q&A module on Zoom. Our senior producer, Sherry Keels, and I will be monitoring that, and we'll be trying to incorporate those questions throughout the flow of the conversation as time allows. Sherry's also going to post for you a link to the panel's bios, because we're not going to introduce them. We don't have enough time. And we'll also create that link in the podcast notes for those of you who are listening via podcast. And it'll give you a really good understanding of some of the great expertise you have in front of you today and some context for all of their great answers. So thank you in advance for checking that out. So I want to start first and set the stage and talk about collaboration amongst healthcare organizations to drive better and more quality community care. And so I'm going to bring in, to start us off, June Simmons. She is the co-chair of the Partnership to Align Social Care. So June, welcome to the show. Thanks for joining us. And I would love for you to briefly let us know what the partnership's mission is, and then provide an example of how the partnership is enabling health plans and CBOs to more easily work together.
Thank you. Yeah, this is an exciting initiative launched this past year, and some of our colleagues are on here representing a wide and unique blend of expertise as we all look at how do we advance population health in America, how do we really align social care and health care. Seems like a nice idea. It's a very disruptive and demanding change that I think is so promising, as we have all learned that the social drivers of healthcare are so vital. And so across a range of organizations, health plans, health systems, community-based organizations, government liaisons, associations, we've joined together, and the official mission is to enable successful partnerships and contracts between healthcare and community care networks to create efficient and sustainable ecosystems needed to provide individuals with holistic, person-centered social care that demonstrates cultural humility. So that's a lot of fancy words saying that we really are trying to build a bold new infrastructure that really allows us to take these two very different ways of addressing the quality of people's lives and their health outcomes, and get them to partner up together. And in order to do that, there need to be major redesigns and changes on both sides. And so we feel bringing these various players in how we address health in America into a co-design where we really jointly look at, well, what would really work. So we're addressing the whole person and their real realities and what gets in the way of having healthy outcomes, the best possible health and quality of life possible in a sustainable way. This is an exciting, beautiful vision, but it really takes the expertise and the realities of all of these organizations to come together so that you have a new marriage, if you will, that requires learning each other and respecting the needs, and then building together new ways of working. So to me, this has been a fantastic assembly of talent. You'll hear from some of them here, but we have the major health plans in America. We have major hospital health systems. We have very important community-based organizations from all across the country. We have a diversity representing the great diversity of our nation. We have consumer perspectives, and so all these groups are co-investing their time and their resources to build a new system that works better for all.
So thank you for that, June. I would love, let's bring in GM. She is the Senior Director of Community and Population Health at CommonSpirit Health. Could you now provide an example of how CommonSpirit is leveraging collaborations in general? I think that will provide some context for everyone as we continue on with this conversation.
Thanks, Eric. It's great to be here. I'll start by saying that collaboration is really the only way to align healthcare and social care. This space has everything to gain from collaboration and not much from competition. So at CommonSpirit, we're a health system in 21 states, 140 hospitals, a large provider of Medicaid and Medicare services. And we believe that it's essential for communities to lead, build, and own the infrastructure for linking healthcare with social care. And as an anchor institution, we can be a catalyst for this effort, but we can't do it on our own. No single organization can, but many partners, including the colleagues here, can and have collectively invested in building the infrastructure the community needs. So in order to collectively invest, everyone asks who pays and what. And that's why CommonSpirit developed the community bank model, and we see it as an effective way to sustain the work. The community bank is a locally controlled community pool of funding. Basically, anyone and everyone can put dollars into a single pot, and the community can use that pot to build community infrastructure to address social needs. And the sustainable and flexible structure of the community bank allows communities to direct resources to where they need it most. And it can be workforce, hiring and training, technology, or integration of technologies, administrative functions like contracting, billing, or reporting. And from our work implementing different models using this financing structure, we see that the approach of community-led community networks can work. And in fact, more community partners are attracted to this collaborative structure. And this allows for blending and braiding of private and public funding as well. Just to highlight how this played out for us, Pathways Community Hub is a nationally recognized outcome-based community care coordination model. Community health workers are contracted through the hub to mitigate health and social risk factors. Now, payments are made each time a community health worker closes a pathway. CommonSpirit invested $1 million to build the community infrastructure across 5 states. The dollars went to provide technical assistance and build capacity. Now, that initial investment has spurred more than $3 million in additional investments from health plans, government agencies, foundations, and other health systems. And I might even be bold enough to say that the work was done in record time. So these health plans and providers may compete on the medical, clinical aspects of their businesses, but the community bank and these community care hub models like Pathways allows natural competitors to come together. So it's smart from a financial perspective, as well as equity and operations. There's cost sharing to build community infrastructure. There's neutrality. It's not branded as one organization's success, but is a community collaborative effort. Communities love it because the work puts them in the driver's seat to co-design a solution. And quite frankly, addressing social needs happens in the community. So their engagement and buy-in is critical. I'll stop there.
And you would, I think what's really important, and I wonder how it's a community, CommonSpirit obviously gets this, but defining internally what's competitive and what's pre-competitive, right? So, I mean, these are all areas that are really pre-competitive. You're not gonna, and you get certainly more efficient in a rising tide for everyone if you work together on it.
Well, yeah, because those resources are out in the community, the assets are out in the community. So we need to figure out how do you link that piece so that you're leveraging what's already out there as opposed to building everything in-house.
Totally. I love the concept. I'm going to bring in Sherry Novick. She is the community health lead for the social health practice at a little known organization called Kaiser Permanente. Sherry, what led Kaiser to the partnership to align social care, and sort of how is it impacting the plan's ability, the systems, I guess the integrated systems ability to provide better social care?
Well, for anyone who's not familiar with Kaiser Permanente, we are both a health plan and a provider. We're an integrated system. So we're operating both from the perspective of being an insurance company and being a very large provider organization serving about 12.6 million members across the country. Just a couple words by way of background. About a decade ago, Kaiser made a concerted decision to integrate an attention to social factors that are related to health outcomes into our care delivery. Our care teams were really clear that they didn't want to just make a referral, which actually we've been doing for many years, when someone has a need, trying to call somebody in the community to help, but actually be able to do it systematically, track the outcomes, know, did this person get the help they need, and ultimately build it into care delivery. What does it mean when people have social needs? So we, to start our journey, we contracted with Unite Us about 5 years ago and started to build networks of CBOs and other health providers across our footprint in more than 40 communities, actually. We knew we were not the only health system entering this space, and very early on started talking with other providers and insurers about working together in our shared space. And as G said, this is not a space for competition. This is a space for building community assets and for working to overcome the differences in culture and practice in the social service world and the healthcare world. So we have been working with direct competitors in California. We're close partners with Blue Shield of California, with whom we compete directly on the California Exchange, for instance. We were, I know G because, and in fact, some would say we're joined at the hip because we work in many of the same communities. We don't all have exactly the same model. We are not approaching it all in the same way, but we are constantly working to build one thing together in the community. The other thing is we're all learning together. And so as I think we'll see today, our paths forward will continue to link. And that's one reason we're really interested in this work of the Partnership to Align Social Care, because it is engaging a lot of competitors, right? Not necessarily direct competitors, but a lot of other health systems. And we know that we are learning together, and why not jump in and explore, more models and more ways that we can address this.
Great setup. What we're going to do, folks, I want to get into some examples, some true bright spots. I see some questions on community infrastructure. I'm going to get to that, how the funds are distributed, measures of success. I'm going to try to integrate those into follow-ups over the next, let's say, 15 minutes, because I think they're spot on with where we want to go. So all those folks who are already asking questions know that I see you, and I'm going to do my best to get them all included. So I'm going to bring in now Tim McNeil. He is a consultant to the Administration for Community Living. He also has his own consultancy called Freedmen's Health out of Washington, D.C. And Tim, I'd love if you can to provide an example for all of us, maybe outside of the care hub, of how the community model, the community care hub model, benefits both CBOs and health plans, and just get people a sense of how it gets applied. So we can get some tangible examples in our mind's eye.
Absolutely. So one market that I had the opportunity to work with is in Western New York, where we're working with a plan by the name of Independent Health that serves the entire Western New York region, based in that Buffalo region, but also serves a rural market throughout the entire Western New York region. And they really began a few years ago looking closely at how they can meet the social needs of their members. They recognized that food insecurity was a major issue, and it was also contributing to readmissions. And so they could have very well just said, well, there's some national vendors that could drop meals in, but we really want a local, homegrown solution that we could sit down with this network and really do resource mapping to identify what are the particular needs for our population. Are there specific areas in our marketplace that's harder to reach than others? Are there specific cultural, linguistic issues that are impacting areas of our community? They partnered with a community care hub by the name of the Western New York Integrated Care Collaborative that goes by the name of WINIAC. And what they sat down and did resource mapping and really identified that there were small pockets of African Americans in very rural areas that had very specific thoughts around dietary practices and other things that a national vendor couldn't really understand. And so they worked together to identify small CBOs, community-based organizations that could meet that need and then service that entire region through this hub. Through one central contracting mechanism, the health plan was able to reach a large span of CBOs to cover a very diverse population. And one of the true success stories, they found there was a rural market that had a large number of their members that had significant health disparities. It was primarily an African American population, and the best resource to address food insecurity in that market was a church that actually had a food kitchen and had a food distribution system. That church is now part of this community care hub, and they're able to have a meaningful contract with the health plan. And the hub is taking over the hard stuff, the HIPAA, the compliance, the regulatory requirements that allows that small church to participate in a meaningful contract where they never would have been able to overcome those complicated contracting barriers. And then to the point about quality, these community care hub worked with the health plan to establish a method to not only track member satisfaction, but also to get input from every person that received meals. And then they meet weekly to see what have been the outcomes. How can we continually adjust to improve the service delivery to meet the needs of the members? So not only are they meeting a clinical need, they're also really identifying that the consumer satisfaction is going off the chart. And that only could be achieved through this partnership with a local network of community that really understands the needs of that local community. And through this hub, it created a contracting vehicle for the rising tide to lift all boats, so all CBOs can meaningfully participate where they would not have been without this hub model.
That's a great example. Could you speak to a little bit around infrastructure? So the question that was asked earlier, I think, is, and G, if you want to jump in here, by all means, when everyone refers to community infrastructure, what do we mean by that? And should this be funded privately by a collaboration like this, or should it be funded publicly? And, how do you reconcile that?
Yeah, I could start here, and then, Tim and June, Sherry chime in. I would say that for us, infrastructure has been around building the competencies and the capacities of our communities to take on this role of administrative functions and actually pay for community partners to do that convening. I mean, usually we always rely on our CBO partners, our community-based organization partners, to say, look, do this on your own dime, do this because you're mission driven, do this because it's something that you're good at and you would have done anyway. But there has to be payment for that. And we have to pay our community partners in a way that recognizes what they're doing in the community. And so infrastructure can expand from actually building an entity that convenes, that facilitates the collaboration. It can be to be a fiscal agent for what I was talking about in our world, the community bank. It can be for technology or any of those integrations, or to make it interoperable, the data collection, the reporting, because a lot of this is new. And many of our community partners are doing this manually or having to pay for their own systems. And so if we're saying you need to connect to healthcare, well, what's the mechanism? And also, we don't speak the same language. Healthcare, social care, social service systems, and community, public health, everyone speaks different languages. We have different measures of success. And so how do we spend that time to come and build that in terms of quality reporting, doing quality assurance, process improvement, data collection, data quality? And so there's a lot of that. I would say, I don't want to just call it administrative function, but a lot of capacity that needs to be built in the community. And I would list some of that as infrastructure, not to mention financing, figuring out how to do that accounting and how to bill and how to contract. And so those are a few examples.
Good stuff. Good stuff. As far as, and I don't know whoever wants to speak to this, but like a fund distribution and where that, who decides where it goes and, how it gets held. How does that work? G or anyone else?
In terms of setting the pricing for these services, is that the question?
Who decides how the funds will be distributed from the network coordinator?
Who gets paid? Well, the hub anchor agency is the contracting entity, but it usually, as G was saying, represents a collaborative of agencies that have been have agreed that they would like to participate and have been vetted as capable of participating. And so then looking at what it actually costs, you know, we've been referring to community services for years and not having to pay for them. But what does it really cost to provide those meals to those rural groups that through that church kitchen that Tim was talking about? They can't do it for free. You don't want a wait list for food. So the anchor agency can lead the studies, the time studies, to see what are the real costs and can negotiate the contract and make sure that the agencies are paid in full and that the overhead for administering that is kept at a minimum. I know the administrative costs are always a concern, and by sharing those, it's much more efficient and that lowers the cost overall than if all these agencies had to contract on their own and do all these functions independently, and the plan had to relate to all those players.
You know, Eric, I would add, from the perspective of a health plan that does in fact contract with entities, for-profit and nonprofit, and those entities often have subcontracts, right, to achieve the goal that we're paying for. The difference here is that those subcontracts are actually assembled, those subcontractors are assembled in the community by the community, so that we are not identifying necessarily. We say what we need. We don't necessarily say, and this organization and that organization, because that's really what the community process is about. So it's a different way to think of what we already do.
Right, and it protects the brand a little bit. Depending, you know, contracting is always a little bit of a tense step, and the collaborative sort of takes that weight off Kaiser's shoulders.
Well, it takes the I mean, we know we are not the experts in social care. I mean, that's a given. The medical industry does not know how to do that. So it enables us to turn to those who do and actually make it work for them, which has been the problem, because mostly everything we've done to date has been voluntary or, you know, networks of organizations. And now if we're actually going to enter money into the system through, you know, new federal policies, we have to deal with what does that mean. You know, the one other thing I think is important is, and I think I saw a question related to this, when we're talking about money, there's a public policy aspect we have to pay attention to as well. You know, it's not all just health plans dollars. It's got to be, you know, some pretty deep thinking about how we fund social services in this country, you know, to collaborate with health.
So I think that's a really
Whose job is it?
Yeah.
Is it all the health plan's job? Is it government's job? Is it neighbor's job? Is it philanthropy's job? Bringing all these sources to look at how do we relieve desperate situations that harm people's health because they don't have access to essentials. Then that's what we're building, trying to think through together how you weave those sources together, because it isn't one party's job. It's a blend of societal members that need to work together to achieve this outcome.
Let's do this. It's a good segue, June. So the partnership to align social care, as you're hearing, you know, obviously focusing on social care and healthcare needs of communities. If you want to accomplish all this, you need different influencers from the different stakeholders in the industry, health plans, health systems, CBOs, government, associations. I mentioned that at the onset, sort of who makes up the membership. If you're curious about who is part of this collaborative and who are some of the other members that are very impressive, why don't Sherry, why don't we put up a poll, and if I'll send you the list of their member roster so that you can have it to get a better understanding of the power of this collaborative and what they're trying to do in obviously in a pre-competitive way, and how potentially it could benefit your plans or providers' efforts to drive better healthcare and better reduce total cost of care in your markets. And with that, I think we should share. And by the way, if you haven't checked them out again, it's partnership 2ASC. So partnership 2ASC.org is the website. I did post it in the chat. Late. Tim, I want to get back into bright spots, and we went into Western New York and talked about independent health. If the model is successful, can you share an example where another health plan maybe has been able to expand it to hit value-based care requirements like HEDIS?
Absolutely. The best example I have there, and it's very in contrast from New York, is in Alabama, where in Alabama, the network of community-based organizations led by an agency in Dothan, Alabama by the name of Sarcoa, that's led by CEO Dana Eatson and her team, they begin really looking at ways that they can bring value to Blue Cross Blue Shield of Alabama, as well as an organization called Alacare, which is the Medicaid long-term service support plan that covers the state. And they began organizing all of the community-based organizations into a delivery system behind a single contract with Blue Cross Blue Shield of Alabama. And they recognized very quickly that as a rural state, there's varying capacities across the state. So they centralized some key functions like IT, quality assurance, and then established a delivery system through this central contracting and central IT system. Once they really began to show outcomes with Blue Cross Blue Shield, they were able to move to a value-based contract model. So this right now today, this network of CBOs began with looking at the social needs across the state of Alabama to a risk-based contract where they are paid an incentive and take financial risk if they don't achieve outcomes. And they're getting the regular list of high utilizers, very complex persons across the state of Alabama who have medical needs. And then to take it a step further, the health plan recognized that there are certain segments of the population where we have never been able to achieve improvement in specific HEDIS measures. So they first began looking at fall risk and even something as complicated as bone density screening for women who in their plan that have had a fall. They train the network of community-based organizations on how to do an initial bone density screen in the home. They deployed this network of community health workers that was linked by a referral from the health plan from a person who had a recent ED visit for a fall, and then gave that network of community-based organizations through this central community care hub called Sarcoa, a value-based contract saying that one, we need to improve our score around bone density screening, and those persons who've had a recent fall, we want your network to deploy in the home to support us with the bone density screening. They have had significant improvement in their outcome measures, and that has led this network to expand their value-based contract with the health plan as one integrated system. So again, very rural pockets of Alabama are able to have meaningful impact on HEDIS scores through this central contracting mechanism that's been orchestrated by an agency called Sarcoa in Dothan, Alabama.
Oh, brilliant. I mean, that's what the show's all about. I love that story. One of the taglines we like saying is finding a bright spot and cloning it. So I want to get into a bit, folks, on how we could clone something like that. And before we do that, I'm going to bring in June to talk about that. I do want to make a quick special announcement. I'm super excited about this announcement. So we've been doing the show for a long time now, but we haven't yet been able to bring everyone to one place face to face. We were trying to right before this little virus broke out in early 2020, but we're going to go at it again in 2023. So what we're going to do is we're calling it an executive roundtable summit. It's going to be a day and a half. It's going to be just a few keynote presentations, and most of the 2 days are going to be bringing people together in roundtable discussions. It's meant to be small, intimate, focused on payers and providers, along with our partners who are going to be supporting that event. And it's meant to have a peer-to-peer discussion like we're having there today on different topics over the next day and a half. So if you want to get more information on this, it's going to be August 23rd and 24th in Boston. Great time to come to New England, August 23rd and 24th, right after sort of school starts and sort of we kind of come back from vacation. You could sort of extend it a bit. By coming to Boston, we have a waterfront property we're going to be at. We're going to have a wonderful 2 days collaborating with each other at our first executive roundtable summit. So it won't be like a regular conference that you go to. It won't be like health, where it's big. It's gonna be small and two-way discussions. You'll probably get to meet almost every attendee through a roundtable discussion. So if you want more information on that, the registration price and all of that, let us know. Sherry put up a poll there and we'll get you that information. So let's talk about cloning that bright spot, June. What are the plans for building community care hubs across the country, and how do we clone things like the Blue Cross Blue Shield Alabama example and take them to scale?
Well, this is our next stage of development, but a great deal of work has already occurred over the last decade. Many states now have community care hubs. They're known by different names. Certainly in California, Partners in Care Foundation has had a statewide community care hub for 7 or 8 years, working with some of the major health plans. And so building that through a stronger business infrastructure, but then continuing learning collaborative, building out best practices, drawing out with stronger information systems so that we can all identify and document the things that work the most. Sorry for those dogs. Close the door, but they're loud. So there's a whole second stage of this work that will be rolling out next year that will build on the work that the Aging and Disability Business Institute at US Aging has done, the work that Pathways Hub has done, the work that Lutheran Services of America has done. There are a number of players that have put together advanced programs that you heard Tim speak to, and Tim's consulting with many states. Medicaid is transforming in many states in America to further address the major social drivers that erode health success. So building learning collaboratives together, and the Community Care Hub represents a learning organization in partnership with healthcare providers and healthcare payers. We have hospitals and we have health plans, and we're building now relationships with medical groups as well, American Medical Association, the Family Practice Association. All these groups really need to build this. We're building some new partnerships with major medical groups here in Southern California to really say, if we're going to build an infrastructure, if we're going to have a way, we have to target the right populations. The community needs to really bring the right curated kinds of interventions. As G lifted out through the Pathways Hub, you need a way to determine what's working, what constitutes success, what are the metrics of success, what constitutes real changes that come from these investments in changing the way we care for people, and what are, so for instance, one of the areas we look at is a large population with a problem that causes a lot of suffering, and it's very expensive, because in a sense, we're helping to reallocate some of the health dollars to other investments that support community living. So nursing home diversion would be a very major area of this, but so is maternal child health, helping assure that adequate access to timely early prenatal care and immediate postnatal care, and planning for future spacing, all of these pieces that are crucial and require consumer empowerment, consumer education, and the provision of concrete resources that help people overcome the barriers poverty brings. These are the ways that we are going to structure and locally customize capacity building interventions across the country. You just heard Tim consulted with New York as they were building out. I thought his Western New York is a wonderful example of how you build capacity. You talk with organizations, you see what they can do, you see what their limits are, you see how to fill those gaps so they can be successful without having to medicalize or structure themselves as corporate. You get the best of their natural resources and you support them so they can be successful and not be harmed by stepping up for the people they care for.
So let's get into some tangible steps for the audience now on how they could do this. And I'm going to bring back GM. She's again the Senior Director of Community and Pop Health at CommonSpirit. G, what's the blueprint at a high level for creating a community care hub? And then I'd love you to also comment on mistakes that maybe you guys have made that you could advise everyone on how to avoid.
Okay, Eric, the partnership work will certainly publish a more comprehensive blueprint for aligning healthcare and social care, but from our experience and my experience at CommonSpirit, we need these three major, I would say, ingredients or components. The first one is identify key community champions who are trusted in the community. They can be, they're community focused, who can lead. They're like a backbone organization, or for those who love football, they're like the QBs of the community. Part of having a community focused entity is to include community voices. You heard from Tim and Sherry and June that inclusion of community voices, the diverse community members have to be contributing to the problem identification, the design, the implementation, and the sustainability. And so, so that's first. Second one, I would say governance.
Give a quick example of what a community champion may be, just
so in one of our communities, I love to highlight San Joaquin, California. They're a United Way that is in San Joaquin. They are the backbone organization for our work called the Community Network. They convened and have brought funders. I believe today there's 12 funders who they have brought together to contribute into the community bank to help sustain the work and fund the work. But they're also convening. They're also bringing in community-based organizations that would have never been a part of a community collaborative had it not been for them to say, no, we need to have this grassroots organization a part of this community network. We need to have these other organizations. And so they're really kind of, making sure they're that friend in that party who's like, no, you need to meet this person, you need to include this person. And they kind of bring the community together to make a cohesive network.
Right.
I would say, so for second, governance, and actually, let me rephrase that, community governance. And the work isn't led by, so this is so that it's not led by one, let's say, entity. It's not led by one health plan or a hospital or a technology vendor. In fact, it's best when all these multiple stakeholders like FQHCs, government agencies, grassroots organizations. And when I say government agencies, I'm not just talking about the county public health agency, but the schools and the school districts, right? And faith-based organizations like the churches that Tim mentioned, community organizers, as well as organizations, all come together and structure themselves under a community governance so that there's equal voices and a diverse voice of who and how the dollars get spent out. And this governance is really critical because it's not to say, just because CommonSpirit Health is funding this program, we get to decide what happens. That's not what we want to build, right? We want to say we're help financing it, but we want the community to come to consensus around, is it hiring for workforce? Is it the technology? Is it the billing and contracting? Is it the data reporting? What is needed in the community to make this network work? So by the way, having this community governance allows for a stronger network because effectively the network doesn't go away because one pulls out. Just because CommonSpirit changes our priorities, that doesn't mean that the network crumbles or discontinues. It continues to happen, right? And so that leads me to the final component, which is sustainability. We really want to encourage, part of the blueprint is really to encourage some sort of funding mechanism that's going to allow for sustainability. And it can be what we are calling a community bank, but others are calling a wellness trust or what Len Nichols and Lauren Taylor, what they built with the CAPG model, the collaborative approach to public good investments. This type of model, but take a look at any of these collaborative funding models so that there's not one agency that has to pay, because no one wants to do that. And then for what is considered to be shared amongst the community.
I'm sorry, I didn't mean to interrupt you. I just want to grab that acronym in that organization so Sherry could put it in the chat for everyone.
It's Len Nichols from Urban Institute, Lauren Taylor's with NYU. They developed a CAPG model. It stands for Collaborative Approach to Public Good Investments. And what they have done is really a fascinating model. They also have a trusted broker in this type of model where we call it a convener. They call it a trusted broker, but a neutral entity that takes that really takes bids from multiple different stakeholders to say, can we collectively fund a public good investment, like a community network, or to invest in social determinants of health and social needs. And then one last piece that I will add, Eric, here is that around the funding or sustainability is that we need to make sure that CBO partners are fairly compensated for what they're doing. And that the outreach, the engagement, the trust that they're building on continuous trust, the education and engagement. And we're not talking about making a referral. And remember that technology is a platform to coordinate and enable that, but it's not the actual services or goods that people need. So we need to pay for what people actually need, which are the goods and the services that our community partners are doing. So those I would say, and then, I'll make this real quick for the pothole. Don't do this alone. Don't do this alone. One reason why we're participating in the partnership work is effectively to avoid this pothole. We believe that to enact sustainable change in the most effective and efficient way is to partner. And within our own system, again, we're in 21 states, 140 hospitals. As much as we can do, as much as we can possibly replicate our own bright spots within our own organization, we will always be limited if we don't partner and learn to scale our work so that there's state and federal policies that align and support the overall work. And so you see the community hub models never existed. They have existed for a while, but they don't have these dedicated funding from federal and state governments to build this type of infrastructure. So if both healthcare entities and CBOs really come together and advocate for this community infrastructure funding by demonstrating success over and over, which it has, then we can really be strategic about building these social determinants of health solutions, not in-house, because we can't really do this alone. We got to do this with partners.
That's great. So I'm going to summarize very quickly because I know we're tight in time here. Identify key community champions like the United Way. 2, stakeholders need to be structured under a corporate governance. All the stakeholders, that includes public organizations like school systems, FQHCs, faith-based community organizations and organizers, etc. And then sustainability, a funding mechanism. So those are the 3 key pillars if you were creating a blueprint. And then the key is don't do this alone as far as potholes to avoid. Did I summarize that?
Eric, that is an A+ right there.
That's good.
And and Tim and Sherry, please chime in, and June chime in here around some of the other things that we're working on, because we're doing a lot around contracting and billing and coding and really identifying what are the functions of a community care hub and what are the standards that we need to hold them up for. So these are all the components that will go into the blueprint. Hopefully, in the next.
I'm trying to go there right now. I know we only have 11 minutes. So I have a follow-up question from one of my co-moderators out there in the audience. Does CommonSpirit account and track the funding for community hub development and claim it as credit for CMS community needs assessment benefit?
Sometimes, so that's a great question, and I know there's a lot of conversations right now with nonprofit hospitals and community benefit expenditures, and this could potentially be where it's coming from. But this is a great way to revert charity care dollars or community benefit dollars to really investing in the community, because what you're doing is you're building things that are sustainable and it's not just transactional. And so I would say that, yes, we are looking at, these grant dollars that we're giving out to build that infrastructure. We do count that as community benefit because it is just really going out. And what we're trying to do is use our community benefit dollars to leverage other dollars that are out there to say, let's get in this journey of supporting the community in a way that they need to be supported.
Sherry, what about at Kaiser? Are you able to take credit?
It's a mix. It depends on what we're doing. We do use our community benefit dollars to make grants to organizations to facilitate their participation. Do they need to upgrade their own technology? So yes, we do some of that, but it is only in part because this is really part of care delivery. And so when we're meeting the needs of our own members, we do not use dollars that we claim as community benefit dollars. So yeah, it's a little bit of both. And I would agree with G that leveraging dollars, and really what June said earlier, we all have to be leveraging our dollars every which way to push us forward.
So Tim, plans and providers, they're doubling down on SDOH and social determinant of health related programs. What in your mind and in your experience, not your mind, makes a successful program different?
Sure. So I just had the great opportunity to visit with a community care hub that's organizing in Toledo, and they're working with ProMedica. And they begin first with saying, what is the need? What's the major need in our community? And how does that contribute to healthcare costs? That market identified that housing insecurity and food insecurity were major issues. And then they said the next step is, we know that there's not enough money on the payer side from a health plan to fix everyone's food insecurity and housing insecurity needs. So what resources can we as a network of community-based organizations amass together to blend and braid to meet the needs of the population, and where we run short, maybe healthcare fills in. And so those best practices are, one, identifying all of the resources at the community level. What is the need we're trying to solve? Partnering with healthcare to co-design the delivery. And so in the example in Toledo with the Area Agency on Aging in Toledo, we recognized very quickly that within that agency, they're able to enroll people in SNAP benefits. They have home delivered meals that are funded through federal and state dollars. They also did level of care determinations. So they said, if we really organize that into a delivery system, now when a person hits the hospital, that's ProMedica health system, that is one of the members that's in a plan, before their discharge, we can make sure they're enrolled in SNAP. We can give them bridge meals. And then if there's a gap, then the health plan could fill in. But then we're really solving a long-term, broader problem of food insecurity, not just giving someone 2 weeks of meals and saying, they're back after 2 weeks. Really blending and braiding all available resources where the community says, this is what we bring to the table, and how can we amass that into a delivery system to meet the needs of healthcare in our market.
Tim, I heard three things there. I want everyone to hear and make sure you keep me honest here. One is you identify the major need and understand how it impacts healthcare costs. In this example, you said housing and food insecurity. Two, you identify the key community-based solution providers like SNAP. And then three, and I think this is the money shot, is you need to figure out how to integrate that benefit into the care system, so it becomes part of the care system, and it's not, like you said, 2-week thing and then they're stuck back in the same position. So those are the three things I captured from that.
Absolutely. And they recognize right off the bat that if they can really get to, I was former military, so we always speak about the tip of the spear, right? So we can get to the tip of the spear where there is the problem. That is much better to get to someone who has a nutrition sensitive condition that's causing repeat admissions to the hospital and driving up healthcare costs. If I can get to the heart of the problem and bring the enrollment to them, instead of discharging them saying, well, we went into this technology system, we found that there's a SNAP enrollment center. I really hope you get to that SNAP enrollment center so that you can get the food that you need. this community in Toledo said, we're going to bring the SNAP enrollment provider to the emergency room, and we're going to meet the person there. We're going to get them enrolled before they leave the hospital. And as a bridge, we're going to try to find meals to serve them while their SNAP benefit gets turned on. So that is really organized, and an organized approach that brings together a massive community needs, where community said, we know this is a problem. We know it's contributing to healthcare costs. So how can we work better with healthcare to bring down the costs and really improve outcomes for all?
Great stuff. It reminds me, by the way, of a book that I read, Measure What Matters by John Doerr. If you guys are OKR students from Andy Grove, it seems like this is really a good fundamental strategy to incorporate into this whole conversation. It's a great book. If you haven't read it, I'll put it, you just Google it. So last couple of minutes that we have here. First of all, one of the things you said in the feedback form in previous shows, and by the way, you already have a feedback form in your inbox now, so go take a look at it, provide us feedback, was you like when we pre-register you for upcoming shows. So Sherry Keels is going to put up our next 2 live shows. If you want us to pre-register for you for them for live attendance, we'll be happy to do that, so you don't have to do any other work. June, there's a question from the audience that I kind of want to close out with, and that's about, do we have cost savings info, papers, or anything similar that we could allude to or reference for our audience to get even a better feel for how this could benefit their organization?
There are across the country many studies that give evidence to the success and the impact, both in changed lives, in changed health, and in financial impact of these kinds of models. And we're assembling those because they're not all in one central place. So very shortly we will have those. So if people will go to our website and express their interest in being on our distribution list, that's part of the role of the partnership, is to really pull together all the kinds of core pieces of summary information that help people who are all grappling independently, reinventing the wheel on their own. How do we jointly draw from dispersed experience? You can hear Tim. We could just interview Tim and write down what he knows, because he works with so many states, and we would have a summary of a variety. So we're building those tools because it's whether it's food or it's transportation, whether it's reducing readmissions to the hospital, whether it's reducing frequent ER use because someone is lodged in a medical home, whether it's housing. There's a wide array of places where there's a value proposition that joining forces to identify people at risk, to see huge gaps in their lives that result in terrible health outcomes and mental health outcomes, and jointly weave together funding so we can bring solutions and we can establish the proof so everyone feels safe. This is a good investment. This is not a money pit. It is a wise way to improve health in the community that we can't afford not to do, but it has to be done right. It has to be done together.
One of the things I would like to do, if it's possible, I don't want to put you too much on the spot, we did not prep for this, is when we follow up with everyone with the recording, and we send everyone the recording, folks, forward it to your friends, family, maybe we could include a link or two to a white paper or study so everyone can have easy access to some sort of proof point on this kind of initiative, because I think it's such a powerful initiative. All right, great. I ran out of time. We got like 7 questions from the audience, 2 that I planned for our panel, and we're out of time here. I want to thank everyone for your great preparation for this episode and all the great knowledge that you convey to our audience. So thank you for all of that, and especially to all of you who are listening. Those of you who are listening to the podcast, all the acronyms you heard, all the little links we alluded to, we'll put it into the show description so you have it right there on your phone or tablet when you're listening right now. But I want to thank everyone for listening. We try to create content that's valuable to you, that could be applied to your job, applied to your organization. And I always like ending the show with reminding everyone that this is your Bright Spots in Healthcare podcast. Have a good day, everyone.